I appreciate everybody joining us today for today's session. Next slide. As Sarah mentioned, this is part 3 of our 5-part series on the use of immunotherapy for liver cancers. And today's session is going to be translating data into practice, the role of immunotherapy in the management of advanced HCC. Next slide. I'll introduce myself. So my name is Adam Burgoyne. I'm a medical oncologist at UC San Diego. And I'm joined by my friend and colleague, Dr. Kelly, who I'll introduce herself.
Hi there. Thanks so much, Adam. I'm Katie Kelly, and I'm a GI medical oncologist focusing on hepatobiliary cancers at UCSF. And thanks so much for the invitation to join you tonight, Adam.
Great. Thanks, Katie. You can see here our planning committee members that helped with the development of this series and content are listed on the right-hand side of the screen as well. Next slide. These are our disclosures. All of our financial relationships have been mitigated by the France Foundation. Next slide. These are our accreditation and credit designation sources here. So you can see here our partners in this educational venture, as well as a link to the syllabus. And just a note that this is supported by an educational grant from AstraZeneca. Next slide. So our sessions for today are to hopefully, after our discussion, learners will demonstrate improved abilities to compare and contrast clinical profiles of immunotherapies for the treatment of advanced HCC, to formulate a plan that considers patient-reported outcomes and perspectives in patients with advanced stage HCC, and to develop strategies for effective multidisciplinary communication and coordination for our advanced HCC patients. Next slide. So our agenda, we've done our introduction. So we have a content portion of the evening, which is really assessing and managing guidelines for advanced HCC, talking about staging, our main immunotherapy treatment options for our advanced HCC folks, a brief review of molecular testing in HCC. We'll have a bit of a summary and update on preferred immunotherapies for HCC and where our field is heading, summary of previous findings, long-term real-world and patient-reported outcomes. And then we'll end the session today with a multidisciplinary discussion and hopefully have an opportunity for this to be as interactive as possible. Feel free to bring any cases or questions that you have to myself and Dr. Kelly. We do have a case that we can present and kind of give an example of how we think about multidisciplinary care for our HCC patients in the advanced setting. Next slide. So we're going to start with just a pre-content knowledge check. So I'm going to read this question and, please take your phones out and try to answer this question using the QR code shown on the screen. So which best describes overall survival data for systemic HCC treatment regimens identified as preferred first-line approaches in current NCCN guidelines? So choice A, median overall survival was about 12 months with atezolizumab plus bevacizumab versus sorafenib. Median overall survival was about 12 months with durvalumab, the STRIDE regimen, versus sorafenib. Choice C, respective 4-year overall survival rates with atezo-bev and sorafenib were approximately 25% or 15%, and respective 4-year overall survival rates with durvalumab or STRIDE versus sorafenib were approximately 25 versus 15%. So give everyone a moment to think about those choices. And please code your answer using the QR code. And if you don't know the answer, hopefully by the end of today's discussion, you'll feel more confident when we have our post-test. Give everyone just another moment. And then maybe let's go ahead to our next slide. And I'm going to hand things over to Dr. Kelly to kick us off.
Great. Thanks, Adam. Next slide. So we're focusing here on advanced HCC, and I think many of you have heard earlier segments of this educational activity that focused on earlier stages as well as leading to the diagnosis and staging of HCC. So here we'll take off from a screenshot of the NCCN guidelines, from a case from the setting of a confirmed setting of HCC. And just as a quick reminder for those of you who weren't on the prior sessions, that HCC can be diagnosed radiographically in the appropriate context. Appropriate context means someone who has known underlying liver disease, such as hepatitis B, hepatitis C, or fibrosis or cirrhosis from other causes, sort of in a nutshell. In those cases who have known underlying liver disease, if a tumor in the liver has appropriate radiographic characteristics, that is arterial enhancement and portal venous washout on a 4-phase or at least a 3-phase imaging study, often measured by what radiologists now call the LIRAD system. So LIRADS 5 would be considered diagnostic for HCC. In those patients with confirmed underlying liver disease and a LIRADS 5 imaging, we don't necessarily need to biopsy HCC to proceed with systemic therapy or other treatments for HCC. However, as oncologists who see a lot of HCC and cases that are called HCC that don't end up being HCC, we always want to remind people that when in doubt, get a biopsy. And if the imaging does not meet LIRADS 5 criteria, or if the patient really has 0 risk factors for HCC, a biopsy is generally a good idea in a patient who might be fit for systemic therapy, particularly patients who could have underlying cholangiocarcinoma, which is treated very differently. So starting with this left box outlined in blue, assuming you've either confirmed a diagnosis of HCC, either radiographically or histologically with a biopsy or both, the next step is to perform a multidisciplinary evaluation. In HCC patients in particular, it's really important to assess the underlying liver disease because it's such a common comorbidity to have fibrosis, cirrhosis, viral hepatitis. And so this includes viral hepatitis panel and appropriate treatment if patients are positive for Hep B or Hep C, as well as assessing their liver function either with Child-Pugh or MELD or ALB scores, which are composites of clinical as well as laboratory parameters in most cases, and then staging for extent of disease, including chest imaging, either bone scan or PET imaging if there's concern for bone metastases, such as patients with significant focal bone pain or a finding that's suspicious on their cross-sectional chest or abdomen imaging. And really importantly, with the abdomen and pelvis CT in the footnotes of the NCCN guidelines, it's very clear to remind people to get quad phase or multi-phase. At your local imaging facility may have several different names for this, but the point is that we need arterial and venous phase, portal venous phase imaging to appropriately measure the capture the contrast phases in a liver tumor. And then the branching algorithm takes us to patients with potentially with earlier stage disease, with this upward arrow highlighting patients with resectable or transplantable or operable tumor burden in the top, which again have been covered in earlier sessions. Liver confined sort of intermediate stage disease in the middle, also covered previously. And then in the red box, what we're talking about today, patients with more advanced stages, either largely extrahepatic or metastatic disease, which are advanced stage. But as we go to the next slide, we'll also highlight that patients with intermediate stage may also be eligible for systemic therapy. So this slide is an important one to pause on. This shows a very widely used liver cancer staging algorithm called Barcelona Clinic Liver Cancer, or BCLC. That's pretty well known throughout the world. And BCLC divides patients simplistically into early stage, which is tumors that are usually curable with some sort of liver surgical modality, intermediate stage that are too many tumors to be cured by transplant or surgery, but can be treated locally, advanced stage BCLC-C, which are tumors that have spread outside the liver, either in a blood vessel or in a lymph node as shown here, or frankly metastatic disease. And then terminal stage BCLC-D encompasses those patients who have end-stage liver function represented in the cartoon here with a cirrhotic, fibrotic liver that are really not usually candidates for therapy and need to undergo best supportive care, palliative care. And I just want to highlight this red box here around advanced stage. Historically, we reserved systemic therapies for advanced stage patients that were truly metastatic or had extensive vascular invasion because our systemic therapies weren't very good. But now with the advent of combination immunotherapies and the recognition that this intermediate stage box to the left, the BCLC-Bs, is a really heterogeneous group ranging from 5 or 6 tumors like shown here to say 20 tumors that can also be still confined to the liver technically, but way too many to do Y90 or TACE or radiation or any liver focal therapy. We need to have this red box encompassing those more advanced intermediate patients, especially as our systemic therapies are more efficacious. Based on the efficacy of our systemic therapies and the fact that there are these much more advanced intermediate stage, sort of the advanced side of intermediate stage patients, the guidelines, including BCLC and NCCN, now include the more advanced intermediate patients for systemic therapy treatment algorithms as well. So next slide. So this is another snapshot of the latest NCCN guidelines, where we take the clinical presentations that we're again focusing on today are definitely the extrahepatic and metastatic stage 4 patients, but also those extensive intrahepatic, the more advanced of the intermediate patients that then can be considered on a systemic therapy pathway. We do, as mentioned earlier, we do prefer to get a biopsy in these patients to confirm the histology before embarking on systemic therapy. It's not mandatory for patients who have a clear-cut radiographic diagnosis, but it is a good idea in patients who have any borderline features, or if it's needed to confirm whether a tumor has metastasized or not, if it's equivocal radiographically. And then systemic therapy is shown here in the red circle as the best option for patients who are fit for treatment. Clinical trials, of course, are always recommended if available, because while we've seen great advances, we still have a long ways to go. Next slide. So just to pause a moment, we talked about biopsies a moment ago on the last slide. Molecular testing thus far does not have an established role in HCC. We're certainly always interested to see what the tumor holds in terms of mutation pathways, and we do know that there are driver mutations that recur in HCC, with the most common players shown here in the italicized genes, including the Wnt pathway, PIK3CA and AKT pathway, RAS pathway, IGF, Wnt beta-catenin, P53, and TERT. But unfortunately, there's a reason that we don't recommend systemic, rather tumor next generation sequencing as a whole, because none of these common mutations have a readily available targeted therapy associated with them. And so while these are drivers, they are not actionable to date. There are a couple of clinical trials coming down the pike looking at targeting several of these particular pathways, but none of them have established themselves as approved treatments to date. So right now, I think Adam and I both would agree, and the NCCN guidelines as well, would support doing molecular profiling on a case-by-case basis. I do it in patients with atypical histology, as mentioned here, patients for whom we suspect that there could be a combined cholangiocarcinoma component, either based on the histology or based on the imaging. Patients who have a really unusual clinical presentation, such as really young patients where we aren't sure if it's maybe a scant tumor that could have fibrolamellar or some other type of tumor, and for patients who need profiling as part of a clinical trial, of course. There's also not much data that HCCs are hereditary, so there's not a general recommendation for germline testing, but certainly if you have a patient that has a strong family history with multiple first-degree relatives or multiple tumors in one patient, I do send them for germline testing, again, on a case-by-case basis, not as a routine. And then the last point in terms of when people ask, what about MSI testing? What about PD-L1 testing or TMB? Actually, immune checkpoint inhibitors show benefit across the range of results for these analytes, meaning patients with microsatellite stability show response to immune checkpoint inhibition. People with MSI high don't have a differential benefit. So there's really no role for testing these to gate whether or not to give immune checkpoint inhibitors, since they benefit across the board for those markers. Next slide. So here's a map of the places that we use systemic therapy on the tumor immune microenvironment level. And on the left in the red box, we see what's really revolutionized our therapy over the past 5 years or so with the advent of immune checkpoint inhibitors targeting not specifically the intracellular tumoral signaling, unlike years past, but instead the immune checkpoint interactions between tumor PD-L1 and a T cell or other immune cell PD-1. where we have PD-L1 inhibitors, durvalumab, atezolizumab shown here in yellow, that target PD-L1 component of this relationship. And then here in pink, the PD-1 inhibitors that are available that have some data or FDA approvals that are appropriate in HCC, nivolumab, pembrolizumab, tislelizumab, and dostarlimab that are PD-1 inhibitors. Other immune checkpoint inhibitors, ipilimumab and tremelimumab, are CTLA-4 inhibitors and have shown survival benefit and improvement in outcomes, either in combination with durvalumab for the case of tremelimumab, which we'll go into in more detail in the first-line setting, or the combination of ipilimumab with nivolumab, which has been FDA approved in the second-line setting and has some recent first-line data. To the right, this slide also shows the tyrosine kinase and multi-kinase inhibitors at the tumor cell intracellular pathway signaling level, which have shown survival benefit in either the first line prior to immunotherapy or as a second line after sorafenib in historical studies. You can see sorafenib, lenvatinib, regorafenib, cabo, and selpercatinib have different targets in HCC. And then bevacizumab is something that is a combination partner with atezolizumab from the well-known atezo-bev regimen that provides a complementary or synergistic inhibition of VEGF signaling to complement the immune checkpoint inhibitor activity at the immune microenvironment level. Next slide. So this is one of my favorite slides from the NCCN guidelines these days, because when I first became a member of the NCCN guidelines way back in the early 2010 era, probably around 2012, this slide didn't even exist. There was no systemic therapy slides for HCC in the HCC NCCN guidelines. There was a tiny little bullet that said sorafenib or clinical trial or palliative care lumped in with all the other local therapy options. And it was not until around 2017 that this slide was created with the advent of something other than sorafenib, which was when lenvatinib hit the scene. And now we see that there are so many choices, both in first line as well as in subsequent line. So we can really start to tailor what we give patients according to comorbidity profiles and according to other patient factors. How far away do they live from our infusion center? Do they have really low burden of disease and want to start with a pill therapy for whatever reason, et cetera, et cetera. So it's really exciting to have at least some choices. We clearly need more since HCC is such a large, complex tumor. But this is, again, a huge advance, probably one of the fastest renaissances in oncology in just a 5-year window. Next slide. So we're going to delve a little bit into the first line setting next. And so this table really shows the 2 FDA-approved combination immunotherapy options that are now available in the first line to choose from for our standard risk HCC patient. The first of these is a combination of atezolizumab plus bevacizumab in the leftmost column based on the IMbrave 150 trial. This regimen was FDA approved in 2020. And then on the right is the combination of dual immune checkpoint inhibitors, durvalumab plus tremelimumab, based on the Himalaya trial, which was FDA approved in late 2022, and is also known as the STRIDE regimen, STRIDE. So you'll hear it mentioned in a couple different ways. The STRIDE regimen stands for single dose tremelimumab with regular interval durvalumab. So starting on the left-hand column with the atezo-bev, the indication per FDA label is shown here, unresectable or metastatic HCC. So this includes sort of the advanced intermediate space that are too many tumors for resection or local therapies, and for patients who are systemic therapy naive. We will add the asterisk for both of these trials is that these studies were conducted in patients with Child-Pugh liver function and ECOG 0 or 1 performance status. So very fit patients is what the data is based on. And very fit liver function in particular within this disease of HCC, which is usually a combination of both tumor and liver disease. So key contraindications or things to know about with atezo-bev are that, those of us who are medical oncologists are well aware of bevacizumab's liabilities as a strong anti-angiogenic inhibitor of VEGF-A. And it does confer bleeding risk. And so in HCC patients, we worry most about GI bleeding from portal hypertension and its complications such as esophageal or gastric varices. So the IMbrave 150 trial required all patients to have had an updated endoscopy within the 6 months prior. And patients with high risk varices at risk for bleeding were excluded, or patients who had had a recent variceal bleed were also excluded. So the really important point is this top bullet: patients who have varices, have a history of variceal bleeding, or have ulcers or other high-risk lesions are not appropriate for BEV. I also think it's important to think about these other points because we do have choices to consider. And patients with high risk, vascular disease, particularly our fatty liver patients who have diabetes and who may have also peripheral vascular disease, if anyone's had recent stroke, if they've had recent claudication or recent cardiovascular events, cardiac disease, those patients were excluded from EMBRAVE 150 as a trial, and also would be somebody that might be higher risk for some of those game over, really serious complications with BEV. Others, not necessarily absolute contraindications, but relative contraindications would be high-grade proteinuria, such as in a diabetic patient, someone with really labile hypertension. We know bevacizumab can be difficult to manage in those patients. And then really importantly, this last bullet is true for really any immune checkpoint inhibitor, that they are relatively, if not absolutely, contraindicated in patients with prior liver or other organ transplant, because there's a very high risk of rejection. And in the case of liver, acute rejection is terminal because people can't be retransplanted when they have advanced liver cancer. For the atezo-bev regimen, it's important to note that immune-related adverse reactions can happen. There's about a 10% chance of needing high-dose steroids to treat them. Infusion-related reactions can happen with any monoclonal antibody, and there can be risk of birth defects. These drugs have not been studied in the setting of pregnancy. Common side effects in atezo-bev include hypertension, fatigue, and proteinuria, largely related to the BEV component. Now, turning to durva-tremi, the dual immune checkpoint inhibitor regimen is now available, FDA approved, also for patients with unresectable HCC, including that unresectable intermediate or frankly metastatic patients, based on the Himalaya trial. Now, contraindications to be aware of are, in this regimen, there is a higher rate of immune-related toxicity than with a single immune checkpoint inhibitor, because again, the tremelimumab is a CTLA-4 inhibitor. There's about a 20% chance risk of a more serious immune-related toxicity requiring steroids or immunosuppression. Now, I mentioned earlier the acronym for durva-tremi for the treatment regimen is also called STRIDE, which stands for single tremelimumab regular interval durvalumab. That's important to know, just because one caveat about the CTLA-4 inhibitor, which is that while it does confer a higher risk of immune-related toxicity by including a CTLA-4 inhibitor, it's only given once on cycle 1, day 1 at the very beginning as sort of an induction or priming strategy. And so the risk of immune checkpoint related CTLA-4 related toxicity is much lower than it is with a sequential dosing, say, as we expect with ipilimumab. So the rate of steroids is 20%, which is about half of that of what we expect with the serial dosing of ipi, for example, or serial dosing of tremi for that matter. And the toxicity generally happens just in the first 3 months, right after that cycle 1, day 1. So it has a window of risk that's higher. Again, about 20% chance for immune-related reactions that require steroids. And then just back to this middle contraindication point, this high risk for immune-related toxicity, because it is higher than atezo-bev, this is a regimen where I might choose atezo-bev instead for, say, a patient that has Crohn's disease or some autoimmune risk that I don't want to give them a higher risk of immune-related toxicity. Just like atezo-bev and any other immune checkpoint inhibitor, the second bullet of prior liver organ transplant is also a contraindication, or especially a contraindication for a dual checkpoint inhibitor regimen. And then in the bottom right box, the common adverse events with this durva-tremi STRIDE regimen include typical immune checkpoint inhibitor related toxicities, especially rash and pruritus, also risk of diarrhea, fatigue, arthralgias, abdominal pain. I will add that, again, double down on the comment earlier that the majority of the immune-related toxicity happens in the first 3 to 4 months and then wanes after that. And then that can bring us to the next slide, and I'll hand it back to Adam.
Thanks so much, Katie. That was a great overview of where we're at in terms of immunotherapy in 2024 for our kind of preferred regimens for our advanced HCC patients. I'm going to go over a little bit of the data that supports the use of these regimens. Next slide. And we have this, mostly presented sort of in summary format in the interest of time today. And with all of the kind of caveats of doing cross-trial comparisons, we do have the kind of main key points of these landmark studies shown in this table. So as Katie mentioned, IMbrave 150 was the large international phase 3 randomized open label clinical trial that led to the approval of atezo-bev for our advanced HCC patients. The study population in IMbrave 150 was patients with advanced HCC that were systemic therapy naive. As Dr. Kelly noted, these patients are fit, so good performance status, good liver function, Child-Pugh A patients. And in the intervention in IMbrave 150, patients were randomized to receive either atezo-bev or the existing standard of care at the time, which was sorafenib as the comparator arm. And the endpoints of IMbrave 150 were co-primary endpoints of overall survival and progression-free survival, with key secondary endpoints including response. Himalaya was a trial that was run somewhat concurrently with IMbrave 150, although reported a bit later. This was also a large international phase 3 randomized open label study. The population of Himalaya was advanced HCC patients, again, systemic therapy naive, who had received no prior systemic therapy. Similarly, good performance status, ECOG performance status less than or equal to 1, preserved liver function, Child-Pugh A. A few key differences in the population of Himalaya versus IMbrave 150. Patients with main portal vein thrombosis or tumor in vein were excluded from the Himalaya study population. Those patients were included in IMbrave 150, which is important because those patients do tend to be a bit higher risk, higher rates of portal hypertension, et cetera. And due to the mechanism of action of the interventions, although, as Dr. Kelly noted, EGDs were required for all patients on IMbrave 150 due to that bleeding risk of the bevacizumab. Patients enrolled in Himalaya were not required to have pretreatment EGDs. And again, that intervention, this study was a bit more complex with multiple arms, but the purposes for today's discussion, really we were comparing the two arms of the STRIDE regimen, which is the dual immune checkpoint blockade of tremelimumab plus durvalumab, in comparison to our, again, prior existing standard of care at the time, which is sorafenib. There was also a durvalumab monotherapy arm. You can see here that the primary endpoint was the overall survival of STRIDE versus sorafenib. However, additional secondary endpoints included overall survival of durvalumab monotherapy versus sorafenib, and then other secondary endpoints were PFS response rates and duration of response. Next slide. So let's talk a little bit about kind of the top line data of these two studies. So, we can cut to the chase a bit in terms of what's highlighted in red here. Both of these studies did meet their primary endpoints. These were positive studies, which led to the FDA approval of these regimens for our patients with advanced HCC in the frontline setting. If you look at the IMbrave 150 data, the median overall survival for patients treated with atezo-bev was 19.2 months versus 13.4 months in the sorafenib comparator arm. Reminder that this did have co-primary endpoints of OS and PFS. The PFS endpoint was also met with a median PFS of 6.9 months with atezo-bev versus 4.3 months with sorafenib. The response rate by RECIST 1.1 with IMbrave 150 for the atezo-bev arm was 30% versus 18% with sorafenib. The number of patients that withdrew due to AEs was 22% with atezo-bev versus 12% for sorafenib. We do worry about hemorrhage in all of our patients across oncology treated with bevacizumab. Thankfully, due to the sort of safety built in of requiring patients to have EGDs prior to therapy or prior to eligibility screening, the rates of treatment-related hemorrhage were actually quite low in the IMbrave 150 study, even in those patients treated with atezo-bev, 1.2% treatment-related hemorrhage to esophageal variceal bleeds. The most common AEs were proteinuria, hypertension, fatigue for the atezo-bev patients, and then in contrast for those patients in the sorafenib arm. This is was a very well characterized medication at the time, with sort of expected rates of common side effects of those multikinase inhibitors like hand-foot syndrome and diarrhea. If we shift gears a bit to Himalaya, this was also a positive study meeting its primary endpoint, again, comparing STRIDE to sorafenib, with a median OS of the patients treated with STRIDE of 16.4 months versus 13.8 months for patients treated with sorafenib. You can see here in this graph, or I'm sorry, in this chart, we also do have the durvalumab monotherapy patients listed. Durvalumab monotherapy was shown to be non-inferior to sorafenib, with a median overall survival of 16.6 months numerically versus 13.6 with sorafenib, as I noted earlier. You can see the PFS here. Median PFS for patients treated with STRIDE was 5.4 months versus 5.6 with sorafenib. Objective response rate was 20% for patients treated with STRIDE versus 5% for those treated with sorafenib, 17% for the durva monotherapy arm. Withdrawal due to AEs, 14% for STRIDE, 16.7%, 16.8% for sorafenib. Again, low rates of hemorrhage in this population, in part because we were not using an agent that induced bleeding, but again, also those patients with main portal vein thrombosis were excluded from the study. Most common AEs, as Dr. Kelly noted, for patients treated with STRIDE were really these immune-related adverse events, with pruritus and rash being very common, diarrhea and other immune-related adverse events as well. And then again, sorafenib seeing sort of expected adverse events that we would see with these multikinase inhibitors. So just to kind of summarize, 2 positive studies, both in their own independent study designs showed an improvement in overall survival in comparison to sorafenib, which led to their approval and now routine use for our advanced HCC patients. Next slide. Let's talk a little bit about safety. So for the medical oncologists on the call, I think we're all very familiar with immune-related adverse events in 2024, with really the advent of immunotherapy transforming how we think about administering anti-cancer medicines to our patients, and the resultant complications of doing so. So these are really itises or inflammatory events of any organ system. When we were first starting to think about using immunotherapy in the HCC space, as Katie noted, many of these patients have comorbid liver dysfunction as part of their etiology of developing HCC, and people were worried that we might see very high rates of immune-related hepatitis in the HCC population treated with immune checkpoint inhibitors. Thankfully, that has not borne out to be the case, although we do see immune-related hepatitis in our HCC patients treated with immunotherapy. These are often low-grade events that can be managed with transient hold of immunotherapy. There are patients that have higher grade 3 or 4 events that require the use of corticosteroids. Those rates are a bit higher with those treated with dual immune checkpoint blockade, as Dr. Kelly noted, about 20%. I would say, generally speaking, however, we have become quite familiar with immune-related adverse event management in solid tumor oncology. Next slide. This is probably review information, again, for those of you that routinely use immune checkpoint inhibitors in the clinic, but this is kind of schematic of the sort of multi-pronged approach that we use to make sure that patients are educated prior to receiving immunotherapy, both patients and their caregivers to know the warning signs and sort of the unpredictable nature of immune-related adverse events, that those any signs or symptoms of immune-related adverse events are identified early. A lot of collaboration involved, particularly for high-grade events, depending on the organ system involved. Having discussions with hepatology or gastroenterology or pulmonology or endocrinology or whomever can be helpful in the management of those, again, higher grade events that are more challenging. Acting and treating as soon as possible, including temporary hold of the immunotherapy offending of agent, initiation of immune suppressive events, including corticosteroids when appropriate, adding on adjunctive immunosuppression for patients that are having very severe events, and then tracking and monitoring for resolution, and having a collaborative discussion on if and when immunotherapy re-challenge can be considered if that's safe. Next slide. So with that, I will hand things back to Katie to talk about some updates on preferred immunotherapy regimens.
Great, thanks so much, Adam. Let's go to the next slide. So one piece of data that was presented at ASCO, actually at GI Cancer Symposium, excuse me, in the June of 2023 was the 4-year data from the Himalaya trial, which basically showed us a really exciting trend with the curves here, where we're looking at the long-term durability of survival and ongoing treatment benefit for patients treated with the durva-tremi stride arm versus sorafenib, and the stride arm is shown in blue and the sorafenib arm, control arm, is shown in red. And what we can see with these separation of the curves, that rather than being sort of a temporary benefit, we're seeing signs of a true or durable immune response, and that as far out as 48 months, these patients with predominantly metastatic and advanced intermediate HCC are surviving at a rate of 25% at the 4-year mark, and circled with the 48-month OS circle, compared to 15% for sorafenib. And this has been recently presented also, that a much smaller proportion of those patients went on to needed subsequent therapies, whereas most of the patients in the sorafenib arm who are still alive went on to get subsequent therapies such as immunotherapy. So those patients, the 25% who are still alive in blue, a higher proportion of them are responding still to the original STRIDE regimen. So again, the important point to note is that with the STRIDE regimen, we can really say that we've changed the survival expectancy at this landmark of 4 years to now be 25%. 1 in 4 will still be alive, compared to a much lower proportion previously. Next slide. And then just quite recently at ESMO, about 1.5 weeks ago, the 5-year data were presented, showing again that this top curve, the STRIDE dark blue arm, continues to be pretty level. Of course, there's some attrition year over year, as is expected also just with natural history of, middle age to older age patients. But this benefit continues to be maintained, and hazard ratio is getting even slightly more robust, suggesting that this is really a true durable survival benefit, prolonged response benefit. Next slide. So the Himalaya trial is really the first trial in the history of advanced HCC to track people out to this 5-year, 60-month landmark. And almost 20% of patients are now alive at 5 years. Again, the standard SEER data would tell us that only 5% of patients should be alive without therapy or with our conventional available therapy. So we are moving the needle on the long-term prognosis. And for me, what this translates to in the clinic is when I see a patient, they don't really ask, oh, what can I do to live 2 months longer? They ask, what can I do? What's my chances of making it to my granddaughter's wedding or a graduation, or these life events that are also measured in milestones and landmarks in life? And here we can say, well, of course, I'd like it to, we're aiming for this to get higher over time as we have new therapies. The 25% at 4 years, 20% at 5 years is a tangible number that people can really wrap their heads around, and makes a big difference for that group of patients. A key other point is that we can also predict even higher rates in patients who achieve disease control. So on the right-hand panel, you can see in the dark blue bars, patients who achieve disease control in the STRIDE arm are defined as patients who had either partial response, complete response, or just stable disease as their best response. And the patients who have a stable disease, partial response, or complete response have a 44% chance of survival at 3 years, 36% at 4 years, 28%, so nearly 30% at 5 years. So again, putting that simply, in a patient who gets a nice response on scan, or at least stabilization, we can tell them that their actual 5-year survival is closer to 30%. In fact, it's even higher for those with partial response or complete response. It's closer to 60%, not shown here. Next slide. So beyond these improvements in overall survival that we see with combination immunotherapy, either the atezo-bev IMbrave150 regimen or the durva-tremi Himalaya regimen, we're also seeing improvement in patient-reported outcomes to really solidify that these immune-based responses are not only prolonging survival, but prolonging quality survival. And so both of the two studies at hand in Brave 150 and Himalaya have already gone on to report global health status, quality of life analyses, functioning and symptom scores that show improvement with the combination immunotherapy regimen over sorafenib. Next slide. Now, it's really important to come back to the point that HCC is a very heterogeneous patient group, and it also includes a high number of patients who have comorbidities of liver disease, cirrhosis, and may not be fit clinical trial candidates, and may have been excluded either from the Embrave 150 trial due to their liver function or having varices or ECOG issues, and ditto from the STRIDE regimen may have been excluded for having a main portal vein tumor thrombus or too high of a Child-Pugh score or too high of an ECOG score. So there have been some retrospective real-world studies looking at these regimens in the clinic and in real-world populations with less stringent eligibility criteria and based on clinical discretion. And we see that, as expected, the rates of response are a little bit lower and there are higher rates of toxicity. But patients still have durable responses in these retrospective and sometimes even prospective studies. And importantly, based on the success in the Child-Pugh A or fit liver disease population, there are now prospective studies going on to better characterize what's the safety of these regimens in specifically Child-Pugh B7 and 8 for the studies shown in the blue boxes on the right. So the first trial is called the Kuros trial, looking at atezo with or without bevacizumab in the Child-Pugh B7 or B8 patients prospectively. And then the bottom row of that blue table on the right describes the Sierra trial, which is looking at durvalumab and tremelimumab in several different buckets of organ dysfunction patients, including Child-Pugh B, also including ECOG2, also including portal vein tumor thrombus, varying degrees thereof. So these studies will be really important to nuance exactly how patients do when their prognosis is not so good as a phase 3 trial candidates. Next slide. So that brings us to our knowledge recheck. And so if I can ask everyone to get out your phones or computers and rescan this QR code and re-answer the question from the beginning of the talk, which describes overall survival data for systemic HCC regimens, which are available as preferred first-line approaches in the current NCCN guidelines. So choice A, median overall survival 12 months with atezo-bev or sorafenib. B, median overall survival was about 12 months with STRIDE versus sorafenib. Choice C, the respective 4-year survival rates with atezo-bev and sorafenib were approximately 25 and 15%. Or D, the respective 4-year overall survival rates with tremi-durva, STRIDE, the STRIDE regimen, and sorafenib were approximately 25 and 15%. So we'll give everyone a minute or 30 seconds to answer before we move to our final portion of this presentation, which is tumor board and question and answers. And Adam, I'll turn it back to you.
All right. Well, let's talk about sort of our multidisciplinary approach to HCC a bit. We're doing pretty well on time. We have about 12 minutes remaining for the evening. So before Dr. Kelly and I start to chat about how we care for our patients in a multidisciplinary way, does anyone in the audience have any questions based upon the content we've discussed? Or if, see one note in the chart about it was difficult to scan the QR code. Sorry about that. Does anyone have any questions or cases that they wanted to kind of bring to the group for us to discuss today? If not, we can launch into our content a bit. Next slide. So these are just some kind of points that we think about in how we do multidisciplinary HCC care. So, you know, as we discussed at our initial introductions, I'm in San Diego, Dr. Kelly's in San Francisco. We have probably similar but somewhat nuanced approaches to how our teams work and operate to manage our patients. But it's really important, given the comorbid liver disease, given the sometimes complexity in making sure patients are staged appropriately. As Katie mentioned, some of those patients that have this very heterogeneous group of intermediate stage HCC are those patients best served by local regional therapy or by systemic therapy, that we have all the kind of relevant players in the room. So medical oncology, interventional radiology, transplant hepatology, surgery, palliative care, radiation oncology. And for us presenting those patients either at a multidisciplinary tumor board or just having discussions as we are able to does certainly help us we're thinking about how to manage and triage our patients. So things that we think about would be what would preclude use of preferred systemic regimens, thinking about the overall health status, other comorbidities. As Dr. Kelly noted, do they have a high bleeding risk? Are they a vascular path? Are there significant autoimmune underlying disorders that would be worrisome if they were treated with immune checkpoint inhibitor? And then what's our preferred regimen that's most appropriate? What partners are involved in that decision-making process? Medical oncology, perhaps in concert with hepatology. And then what are the kind of earliest stage in which we'd use systemic therapy? So making sure that we're identifying the best patients. And then throughout patients' HCC cancer journeys, making sure that we're not just prescribers, that we're also supporting our patients. So engaging them with the appropriate support systems, making sure our patients have access to treatment resources, and that we're overcoming any barriers to care, early introduction to palliative care for symptom management, and for our patients that perhaps are more advanced from a liver disease perspective, making sure that we're preparing our patients for end of life when appropriate. Those are, very difficult conversations and sometimes nuanced and balanced for us to have. So any other notes, Katie, on how things are done at UCSF from a multidisciplinary perspective?
No, I think that captures everything. We do have a tumor board and we discuss cases that are on the border of systemic therapy and liver-directed therapy, that sort of nebulous BCLC-B or intermediate stage group. And if they have vascular invasion that's more than just branch, if they have really extensive tumor burden, if they have infiltrative or diffuse tumor features or super high AFP, often we'll move earlier to systemic therapy these days.
Yeah, great points. Well, maybe we'll start with a case to kind of highlight some of these things that we think about. So this is Mr. Short. So this is a 67-year-old man with obesity and cirrhosis, which is attributed to fatty liver disease and prior alcohol use. A multi-phase CT of the abdomen was performed, which revealed a 7-centimeter right-sided mass, which had arterial phase hyperenhancement and washout. There was invasion into the right portal vein, as well as involvement of a periportal lymph node that was enlarged at 4 centimeters. You can see the labs here show a total bilirubin of 0.9, albumin of 3.5, INR of 1.0. Platelets were just over 100,000. AFP was elevated at 327. And based upon our assessment of his performance status, we're thinking that he's an ECOG 1. So, Katie, how do you think about a patient like this?
Now, this is where, the characteristics of the imaging and exactly where that tumor is located. Does it look like a nice confined circle far from any vasculature, or is it diffuse with some suggestion that it could be more multifocal or insidiously invasive? Those are some of the pictures worth 1,000 words questions in my mind right now. That lymph node looks far too big to be just reactive, so that makes me think he probably has metastatic M1 stage 4 disease. Well, actually, periportal would not technically be M1, that'd be N1, but it would be extrahepatic disease. Periportal is regional, so N1 disease. And then obviously the right portal vein tumor invasion also makes him BCLC or advanced. So this is looking like someone we're going to want to use systemic therapy for a variety of reasons: the size of the tumor, and extrahepatic spread plus vascular invasion. And then looking at his labs, the platelets being low make me think that he's probably a portal hypertension patient based on his MAFLD and alcoholic liver disease. And he's definitely someone who all patients should have an endoscopy, relatively recent endoscopy before atezo-bev, but he's someone who probably needs an endoscopy just as a standard of care as well to assess his variceal bleeding risk.
Great. Apart from the portal hypertension that you're worried about and the platelets, what do you think about this person's, protoplasm and general candidacy for systemic therapy, without any other additional information?
Yeah, I think with ECOG 1 and all the data provided, assuming he's not actively uncontrolled as an alcoholic and is safe for systemic therapy in terms of compliance, I think he's a systemic therapy candidate from what I'm seeing here.
Yeah,
Which some of his details will help us choose which systemic therapy, though.
exactly. Next slide. So, as Dr. Kelly noted, all patients in this situation really should be receiving pre-treatment HEDs to assess their variceal bleeding risk. Not surprisingly, based upon that, somewhat low platelet count, there, was evidence of esophageal varices, a sequelae of the portal hypertension. Those were significant enough to require banding. So how do you think about those patients in your clinic, Dr. Kelly, that are perhaps too high of a bleeding risk to consider bevacizumab? What's your next go-to?
The STRIDE regimen is definitely my preferred alternate regimen. And in some cases, it's my preferred regimen, even without varices, which we can talk about if there's time. But for someone who has varices requiring banding, it's important to remember that they're not done with their portal hypertension and their variceal banding. For good EGD management, that patient is going to need, after banding, they need a follow-up endoscopy 1 month later. And during that month, they are at risk of post-banding ulcers and bleeding. So really anyone who needs banding, being banded doesn't mean they're absolved of risk. It means they're actually a little higher risk for bleeding. So I really don't use atezo-bev post-banding, and especially in anyone who's ever had upper GI bleeding from varices. So this is someone I would use STRIDE in just by virtue of that first bullet.
Yeah, I completely agree. And that's what this patient was offered. And after some discussion of risk and benefits and shared decision making, he elected to proceed and received 2 cycles of therapy before restaging imaging was obtained. So following up with additional multiphasic imaging after the first few cycles of therapy is important for response assessment. Thankfully, this patient was one of our early responders, 35% reduction in the size of his primary liver mass, decrease enhancement in the right portal vein. And from a tolerance perspective, Mr. Short's doing okay in the short run. He was having some diarrhea. It was initially controlled with an over-the-counter antidiarrheal, but then eventually progressed to 7 to 10 bowel movements per day. So, Katie, I'm sure you see these patients in your clinic all the time. How do you think about someone like this?
So I'd say first, based on that fourth bullet, to get a partial response is a really good sign. I probably didn't say it as eloquently as I could have on the earlier slides, but if you stratify the 4 and 5 year STRIDE outcomes according to whether patients had response, stable disease, or progression, those patients with stable disease and response have much better 4 and 5 year survival outcomes than patients who had progression, which stands to reason, but it really tells you that at that 2-month mark, especially when someone's facing a toxicity issue, you can say, you know what, you're in a good place because you've had this response and your outcomes are immediately much better. And one thing that's nice about the immune-related toxicity, which I'll talk to you about a little bit more, is that having immune-related toxicity actually correlates with slightly better survival outcomes as well. The immune activation process for some of the toxicities correlates with on-target activity as well, with the immune response wise. And so having this as well, it's dangerous, particularly in an elderly patient with comorbidities, to have immune-related colitis, if that's what this is. Needing a break in therapy is not a deal breaker in terms of him continuing to maintain that response. Even if he never goes back on treatment, those responses can still be maintained. And he can also potentially go back on durvalumab once the colitis or diarrheal toxicity is resolved, because as again, back to the point of how STRIDE is given, it's just a single dose of the tremelimumab, so that the toxicity is really loaded up front into those first 3 to 4 months. And so someone like this who gets a diarrheal toxicity if they recover well, we can consider re-challenging them just with the durva alone later, again, depending on how severe it was and how well they recover.
Yeah, exactly. And in terms of managing this, potential immune-related colitis, obviously we need a little bit more information here, making sure that they were maximizing supportive care, Perhaps we could get this person over the hump with just a treatment hold, making sure that they're taking their loperamide sort of as instructed to minimize the amount of fluid loss that they're having. Perhaps we could decrease the number of bowel movements they have with that alone. Of course, if this became uncontrolled or more severe, considering corticosteroids for those patients. And then as Dr. Kelly noted, thinking about when, if this cools off, we can, potentially re-challenge with durvalumab if that's appropriate. But I totally agree with you, making sure that patients understand this isn't a deal breaker in terms of their long-term outcome. And also for the reasons that you noted, this person's actually in a really good place right now and that they've had such a rapid response and that maybe this immune-related adverse event can correlate with a longer-term benefit.
I will
Next.
interject though, Adam, just to add though that I do think, especially with colitis, that early intervention with steroids is a good idea if you see something escalating sort of 0 to 60 really quickly. Someone has no diarrhea and then goes to 10 a day, then 15, or if they have systemic symptoms like fever, blood or mucus in the diarrhea, because you want to abrogate that immune cascade in the gut as quickly as possible if that's what it is. So I think especially if there's a high index of suspicion, like there would be in the first 3 months of a regimen with a CTLA-4 inhibitor, early colonoscopy, early sigmoidoscopy, and early steroids is a good idea too. Because I have had some that are quite serious colitis cases with tremelimumab.
Yeah, I totally agree. I think we have quite enough information to see like how high grade this person is, but yes. And even if they are on the borderline, I think that's a great point. Watching these people very closely. This isn't a return to clinic in 4 months with no follow-up kind of a person. I mean, we need to make sure that we're watching these things quite closely.
And you can get a sigmoidoscopy even if you can't get an immediate colonoscopy, at least to get an initial biopsy.
Exactly. All right, next slide. I think that brings us to the end. I hope that everybody enjoyed our session tonight, both the didactic content and the discussion. Sure you all want your CME credit for your participation tonight. So those instructions are shown here with the QR code, as well as how to develop an action plan and register for the next session. If you have any questions, please reach out to Sarah for any additional steps. And I just want to thank everyone for their attention and especially thank Dr. Kelly for joining me tonight and co-moderating our session.
Thanks so much, Adam. And thanks to the ECHO sessions planners.